Hope Cook with Dermcast.live. Today we have Dr. Whitney A. Dr. A is a dermatologist and a dermatopathologist, and he's going to be talking to us today about pathology as well as common skin cancers. Welcome, Dr. A.
Thank you for having me.
Yeah. So you are a dermatopathologist. For people who are pretty new to dermatology, why should they consider using a dermatopathologist as opposed to a regular pathologist?
That's an excellent question. So, of course, there are different ways to become a dermatopathologist. You can either be a board-certified dermatologist or be a board-certified general pathologist and then do additional training to become a dermatopathologist. But, you know, there's probably no other group other than dermatopathologists that have the same skill level under the microscope that do dermatopathologists. And it's very, very important. If you need a muffler, you go to Midas, right? So if you need the best interpretation of skin, I think odds are that a dermatopathologist will afford that for you.
Yeah, and are there certain things that we should definitely use a dermatopathologist for, like certain conditions or diagnoses?
Well, sure, yeah. You know, I think, you know, there are certain entities like basal cell carcinoma or squamous cell carcinoma that are lower risk types of malignancy that certainly a general pathologist could probably help out in many, many situations. But then there are challenging things such as pigmented lesions, which would be very, very difficult for anyone to interpret correctly. And so I think in those circumstances, spitzoid lesions, things like that, it's very, very important to have somebody very, very skilled because, as we all know, the interpretation of pigmented lesions is somewhat subjective. There isn't anything we can do singularly to say that something is or benign or is malignant. So it's important to have somebody with skill and experience analyzing the case.
So speaking of pigmented lesions, mildly atypical, moderately atypical, what is the latest in literature about mildly atypical? Do we excise? Do we leave them?
Sure. So an important first step is understanding that, you know, the classification of pigmented lesions, atypical nevi in particular, into mild, moderate, and severe is not uniformly accepted across the country. While it's certainly the most common thing, and the most common in my area, I always make the joke, if you want to eat in Denver, you need to classify pigmented lesions as mild, moderate, and severe. In some areas of the country, they don't believe in grading lesions at all. That's the case in Dallas, in San Francisco. There are many labs there that don't classify lesions into mild, moderate, and severe. That aside, there has been this emergence over the last 10 years or so to consider mild atypia to be not much of an issue, to consider moderate to be kind of a borderline thing, consider severe to be concerning enough to require excision. But I think that standards of care could vary from area to area, and certainly there are a couple papers, one that came out in 2017 and one that just came out this year, that said there's still considerable variation in the analysis of pigmented lesions, and certainly it's not uncommon at my tumor board, for example, at the University of Colorado, to see things that were called moderately atypical nevi only to be later discovered to be melanoma. So I think you do still need to be careful with moderate and severely atypical nevi and really make sure that you're sampling all or substantially all the lesion and that you have some confidence that the person analyzing the case is really skilled with pigmented lesions.
And can you say more about why it's important to biopsy the entire lesion as opposed to just a little corner?
Sure. So you can understand that if I want to understand, you know, what flavor a cake is, like a wedding cake, it's important that I actually get to the cake, right? I can't just lop off the icing on the side and send it off and ask somebody, well, what flavor was the cake? They won't really know. So it's very, very important to make sure that the biopsy that you're getting is representative of the overall process. I once did some mathematical calculations because I'm an engineer. I kind of like those kinds of things. And it turns out that in a 4mm punch biopsy by volume, the dermatopathologist is only looking about 1/500th of the overall specimen. And then if that punch biopsy is then just 1/50th of the pigmented lesion, you have to multiply the two numbers together. So it's important to understand that we're only getting a whiff of what's going on with histopathology. We're not really getting the whole thing, and so you have to have some skepticism about your sampling on occasion.
How often do you look at photos with the specimen?
I think it's fantastic to look at photos if they're made available. The bigger question is how often do we get that kind of information? I would say on a vast majority of the cases that I get from the outside community, I don't even get the size of the lesion very often. So if I don't know the size of the lesion, I'm certainly not getting a photo. So I do think it's important, you know, in some of the lectures I give in other scenarios, I always talk about giving information and how, if you look in the literature, you're supposed to provide, all this detail about the history of the lesion, how it's been changing, things like that. And we just don't get that in private practice or in actual practice. We instead get, nub written sideways, or a now with the electronic medical record, we get something carried forward from patient to patient to patient all day long. So it really is useful to have some information about what your specific concerns were in that case.
And if it's a previously biopsied lesion, why is it important to know that?
I think that's a very astute question for sure. So there's good recognition that recurrent lesions, when they're overlying scar and exposed to that cytokine milieu of the reparative process and things like that, can become very, very atypical looking. In fact, it's referred to as pseudomelanoma. So if I have no idea that that lesion has been sampled before, I might get confused about whether the scar I see is regression or whether it's true scarring, and I might potentially overcall the amount of atypia in that situation. So it is very, very important to provide those kinds of historical facts when they're known. And sometimes I understand, I'm a clinician too, I'm a dermatologist, dermatopathologist, as opposed to a pathologist, dermatopathologist. I understand that patients are confused, they don't tell you those kinds of things, they forget, but it is important to include the history that you know.
Yes, within a scar or previously biopsied. If we see a pigmented lesion, we're suspicious of melanoma, what is the best kind of biopsy?
Well, that varies from situation to situation. Of course, there is an E&M code associated with the visit, and it's very, very much us as dermatology professionals to value that. We need to learn how to look at a lesion and appreciate how would the best biopsy be performed. But in general, if you look at the literature from the 50s and 60s, it says that every single pigmented lesion has to be excised, and that would be impossible. I'd still be working on January's cases if I was excising every single pigmented lesion that I was exposed to. So certainly I understand that saucerization is very, very useful, kind of something deeper than a very, very tangential shade, but kind of a saucer-shaped sampling gets almost the same information as an excision in many situations. And a punch biopsy might be useful if you're sampling all of the lesion, or you're sampling a specific part that you know to be high yield or you suspect to be very, very high yield. That might be appropriate. It's true, and I have a hard time convincing people of that sometimes. You see a patient that it's so obviously a bad melanoma, and the situation is so serious and grave that you actually walk down the hallway and grab one of your surgical colleagues and say, I don't have a good way to biopsy this today, but could you get to it by the end of the week or by Monday? And they say, sure, yeah, that's not a problem. We can get them in. And then you get an excision biopsy when you really need that total experience of the lesion. You need to see all of it and really gauge potential for lymphatic invasion or satellitosis. There are situations where you do nothing that day except schedule the patient for an excisional biopsy. But of course, that's the exception rather than the rule.
Yeah, does the clinician decide on do we need to say anything about which stains to do? Is that completely up to you?
Well, I think that, to some degree you can certainly say, I'm very suspicious of a pigmented lesion, please do a PAS. I'm sorry, I'm very suspicious of a fungal lesion, please do a PAS. You can say, oh, this is a nail clipping, please do a PAS. There are some things that as the clinician that you're going to want done. But certainly, we have sometimes lesions biopsied as potentially a basal cell, and it ends up being a lymphoid condition where you're going to need a whole bunch of specialized markers to try to evaluate if it's a B-cell lymphoma or a T-cell lymphoma or what type of B-cell lymphoma it might be. And in that situation, there's no way for the clinician to anticipate what stains might be done. So I think sometimes you can point to a potential opportunity to use stains or immunohistochemical stains, but by and large, that's the domain of the dermatopathologist to be an expert in how to use those.
And if you do biopsy a pigmented lesion and you still see color at the base, do you recommend taking a deeper?
That's a difficult situation. I'm contending with a lesion like that right now, immediately before I left to come here to San Diego. And I do wonder, they must have been looking at the pigment at the base of the sampling, and I wonder why they didn't go back and try to get a little bit more so that we could be certain we're seeing all or substantially all the lesion. But I understand that those things, are sometimes not crystal clear at the moment that you're doing the biopsy. But I do think it's useful to try to get as much of the pigmented lesion, because for things certainly like blue nevi on the scalp of elderly persons, there's evidence from MD Anderson and some other institutions that melanoma can occur in only a portion of that blue nevus. So if I'm only seeing the top of it, or I'm only seeing the right side of it or left side of it, or whatever it might be, I could potentially miss something that was very, very important to the patient. Even moving beyond pigmented lesions, that's sometimes true with things like tricholemal carcinoma, other adnexal malignancies. Those can occur in only one small area of a larger process, like hidradenocarcinoma inside a hidradenoma. So in those situations, it's important to always recognize that we're only looking at small fragments of a much larger sampling, and we could be misled.
And if you have a super thick hyperkeratotic papule, you know that the top part is just nothing but keratin. Can you tell us the best way to do a biopsy on those?
Yeah, those specimens come into our laboratory from time to time. And certainly, again, if you're very, very suspicious that it's non-melanoma skin cancer, and you feel pretty certain that you're not going to be able to get an adequate biopsy with a shave or a punch, it's probably, again, a situation where you schedule a biopsy that somebody can actually dive down with a number 15 blade and really get all or substantial of the lesion. If you ever find yourself, just like a pigmented lesion, doing a shallow biopsy and then realizing that there's still this kind of homogeneous squamous process, there's a perfect opportunity to go ahead and do a deeper biopsy. Or some people, even from time to time, do a conversion of a shave to a punch, where they first do a shave, take off a lot of the keratin and debris, and then they see, oh, there's definitely more here, and that might be an opportunity to follow up with a punch biopsy. Is it as perfect as one singular biopsy that captures all the lesion? No, but sometimes having two pieces, one shallow, one deep, is better than just having the shallow piece alone.
Would you put those in the same bottle?
I think if it's the same anatomic site, it's entirely reasonable
to
put it in the same biopsy bottle. If you have two biopsies that are pretty disjointed and you're trying to scout out where the lesion is invasive and where it isn't, then an argument could probably be made to putting those in two biopsies. But I think if it's really just a shave and then you, what we affectionately call a whoops biopsy, a shave and then you look and you see that, oh, the thing I really wanted isn't there, that's an entirely appropriate place to put it in one biopsy and spare the patient kind of two charges.
All right, punches. Are we still doing punches on rashes?
I think punches are useful for a lot of rashes, and I don't see a huge problem with that. I will point out that there are some rashes, based on my 24 years in the field, where a shave might be actually superior. For example, in mycosis fungoides or cutaneous T-cell lymphoma, especially in patch stage disease, very subtle disease, you want to see how many of those malignant epidermotropic lymphocytes are moving into the epidermis, right? And so in that situation, even though it seems like a case where you might do a punch, actually a shave might give you a much broader breadth of the dermoepidermal junction to look at. Similarly, in bullous pemphigoid, which is the #1 autoimmune bullous condition, right? And it's gone up threefold in the last 10 years because of our elderly population. It's tempting sometimes to do a punch biopsy because that's how it appears in classic textbooks and things like that. But in that situation, you run the risk of either the epidermis remaining in the punch or separating and getting lost in transport or in emptying the bottle or at the laboratory or anything like that. So in those situations, sometimes with bullous pemphigoid, it's nicer to find a smaller blister and just shave the whole thing off entirely, so that you don't have any of that problem with epidermis staying inside the punch instrument or separating. So I think paradoxically there are some situations where a shave or saucerization actually works best in inflammatory disease, but I think a punch can still be utilized. I don't think, you know, we need to round up all the punches and get rid of them or anything like that.
Right.
I do wish we'd round up all the 1.5 millimeter punch biopsies.
I didn't know there
and
were
get rid
even,
of those.
Yeah.
But that's just, you know, when you ask a dermatopathologist how much tissue they need, they always say more, right?
Yeah. Okay, so we have a rash and we want to rule out atopic dermatitis, or maybe we're thinking it's psoriasis, and it comes back spongiotic dermatitis or sometimes psoriasiform dermatitis. Can you talk to us about how to interpret those results?
Well, you know, to back up one small step, that's where it's kind of useful sometimes to know if your dermatopathologist is a dermatologist or a pathologist by training first, right? So I'm a dermatologist, dermatopathologist. I tend to think in clinical terms. I've seen as many patients as any other dermatologist pretty much. And so it's good to include pictures and descriptions and things like that. And I would consider that as a dermatologist, not only as a dermatopathologist, and try to get you the right answer. There are some things we look for, like eosinophils being more of a Th2 type cell, whereas psoriasis is more of a Th1 disorder, right? There's things that we see that are sometimes inconsistent with psoriasis and more consistent with a spongiotic condition like atopy or allergic contact dermatitis, but those tricks don't always work perfectly because a patient could have psoriasis and then also be allergic to the Gold Bond cream that they're putting on the lesion, and you could see confounding effects from the two different processes. So you do have to be careful about that, but by and large, I think we're able usually to separate what is probably psoriasis from what is probably dermatitis, but clinical data could always help in that discernment, I think.
And it sounds like it's also helpful for us as clinicians to go back and look at the description that dermatopathologists leave, like eosinophils present or...
Yeah, I do see some laboratories, we put microscopic descriptions on most of our cases. I do see some laboratories that on essentially all their cases, they just say microscopic examination performed, and that's all it says.
Yeah.
And that puts you at a little bit of a disadvantage unless they write a pretty generous comment that serves the purpose. But I do think it's useful if you're really stuck in a clinical conundrum to look at things like, are there eosinophils present? It's not thumbs up, thumbs down for a spongiotic condition, but certainly seeing eosinophils is a little bit inconsistent with most psoriasis. And then Langerhans cell microabscesses in the epidermis, that's a little bit more common with allergic contact dermatitis than other entities. So there are soft clues that you can use to augment your judgment, but other things are useful too, like the exact distribution or the family history, or even symptoms. Psoriasis is not a particularly itchy condition for most people, whereas dermatitis and atopy especially is a very, very itchy condition. So there are other soft findings that I think if you take enough of those soft findings, you can kind of push yourself one direction or push yourself the other direction.
Okay, that makes sense. And if we're thinking like Merkel cell, something kind of unusual.
Sure. Merkel cell is a very important consideration because it's deadly, right? Merkel cell is more deadly than melanoma is. It's just very, very rare. So certainly you want to, you know, ask yourself, is this an older person? Is it sun-exposed skin? Does it have kind of a nondescript appearance? Is it the person immunosuppressed in any capacity? Those kinds of things would suggest the potential for Merkel cell carcinoma, but very often we don't know it's Merkel cell carcinoma until we look down and see that you're trying to exclude basal cell carcinoma, and it's clearly not that. So Merkel cell is a real fooler. It doesn't have a specific clinical appearance. It does have a very specific histologic appearance and a specific staining profile, but it is something to always keep in mind because it is just a very deadly kind of skin cancer that's out there.
The dermatopathologist would know, like when you look at it under the microscope.
You would hope, yeah, you would hope that the dermatopathologist would be suspicious that this isn't, you know, it says rule out basal cell carcinoma, and it's not perfect for basal cell carcinoma. I will say that, you know, sometimes I have a saying, you know, tissue is the issue and cancer is the answer. A biopsy could be so small and just kind of nick something purple at the deep surgical margin, and it would put the dermatopathologist at a horrible disadvantage in trying to figure out what that tiny, tiny focus of blue cells are. Because certainly, you know, Merkel cell is a blue cell carcinoma, basal cell carcinoma is a blue cell carcinoma, and a sampling could put the person at a disadvantage, and that's why it's important to always keep in mind, right, I already made clear that I'm a dermatologist. I'm sympathetic to the dermatologist's plight that we can't, you know, lop off a giant shark bite of every single patient to make sure that we don't have a cancer in there. But by the same token, I do see some logic in pointing out to my colleagues that if you've decided a biopsy is necessary, probably want to do a biopsy with enough substance to be useful. And so sometimes when the patient starts saying, well, there's not going to be any scar here, right? There's going to be, I have to really stop and say, well, of course there's going to be a scar. We don't have scarless surgery or anything like that. We have in utero scarless surgery, but we don't have that for adults. But I'm concerned enough about the potential for cancer here that I think a biopsy is in your best interest, even understanding that there may be a scar.
Yeah, I think that's a good point. If you're going to do a biopsy, there is going to be a scar.
Right. If you're going to go out tonight and paint San Diego red, then do it. Then
what about
I think that's what you got to do.
What about deeper sections? Is there a place for clinicians
Yeah, so
to
deeper
ask?
sections, also called levels or step sections, are certainly appropriate. And like I said, in our pathology report, it would say, you know, step levels were performed, or you know, a separate slide containing 3 further levels was examined, however the language might be. But we do try to indicate that we've taken time to move deeper into the paraffin embedded block and try to find whatever you were interested in. I think if you're the clinician and you see that I've done levels and I still can't find the basal cell carcinoma that you were suspicious of, that might put you at ease. But if you see that I didn't find the basal cell carcinoma, which you were highly suspicious of, and you see that I haven't done levels, that might be an opportunity, as you point out, to call and say, would you mind going ahead and cutting some levels? And since I work for you, right, I'm trying to be your colleague in care, my answer should generally be like, absolutely, I'd love to do some more step levels and make sure that we don't have a cancer here. Step levels are free. They don't cost the patient anything. There's no charge for them or anything like that. I guess it is somewhat damaging to the bottom line of the laboratory in that you have to use more time and materials, but I think in the end we all want what's best for the patient. We want to make sure that there's really no cancer there.
Yeah.
At some point I've done 10, 12 levels. I have to say, gosh, I just can't find what you think is there. At that point, you have a choice to, do I need to do another biopsy or do I need to just watch the area? That's a clinical matter that you're going to have to decide upon. But when you get 12, 15 levels out, you're pretty sure that we can't find what you were interested in.
All right, let's talk about DIFs.
Uh-huh.
Is there a benefit to doing your regular H&E and a DIF the same day? Or should you wait for the result on the H&E?
Yeah, so I often do a DIF and an H&E the same day. Very, very often do. When I feel like the yield, the positive predictive value is going to be very, very high. So if I have an 82-year-old woman itchy all over now with blisters in the axilla and the feet, pretty sure that's bullous pemphigoid. I go ahead and do an H&E and a DIF on the same day. And I get those results very, very quickly, and that's useful. If I'm thinking that, you know, this is a 34-year-old man, no chance that they're pregnant, no chance that this is pregnancy-related bullous pemphigoid, and they're itchy and have a rash, my chances of DIF there being positive for bullous pemphigoid are very, very low. I might not do that the same day. But I think you're just playing, you know, positive predictive value. Is this really going to be useful immediately, or should I see what the H&E holds first? And I think you do that just based on the clinical situation.
Okay. And a perilesional biopsy for the DIF, how far from the lesion? Does it matter?
Yeah, so for many, many things, but not everything, you do a perilesional biopsy. For example, bullous pemphigoid and pemphigus, you do a perilesional biopsy, and we move 5 to 10 millimeters away from the blistering process and do the biopsy there. For some things like leukocytoclastic vasculitis, you want the actual lesion. You don't want perilesional tissue. So it varies a little bit from condition to condition, but when somebody desires a perilesional biopsy, they just mean a little tiny bit away. Now, there is one disease, dermatitis herpetiformis, which is technically you should be able to biopsy their skin anywhere on their entire body and get a positive result because it's a systemic disease, right?
Yeah.
But still, we generally use perilesional skin.
Okay, that makes sense. What is your biggest pet peeve as a dermatopathologist?
You know, I think the most dangerous things that we do at the interface between dermatology and dermatopathology is not share information, like we mentioned, the size of the lesion, the degree of concern, things like that. And then, again, a biopsy can be very, very misleading if you just do a portion of it. I can't tell you how many times I've had a squamous cell carcinoma that in hindsight is this big around and I get a little tiny nick from the edge, or a pigmented lesion that was very inhomogeneous and had worrisome areas, and then I got kind of a shave biopsy of the area that was the most convenient, or even taking things that seem trivial, you know, in onychodystrophy, when you're looking for onychomycosis, a fungal infection, you know, sometimes you just hand the clippers to somebody in your office and say, go in 12 and get a biopsy, and they clip the very healthiest nail tissue because it's the easiest to clip. Then you're going to get misled with the results. And so I do think the two things are that generous sharing of information and getting a representative biopsy.
Oh, those are good. All right, quick question. If you weren't in medicine, what would be your fun alternative career?
Well, that's a funny question for me because I've had alternative careers. So I was a chemical engineer for a few years before I became a doctor. And then I also, even though we didn't talk much about it in this particular exchange, I also have a law degree as well.
Wow.
So I would probably either be
though.
a lawyer or an engineer if I wasn't a doctor. And you know, never say never. You know, I'm getting close to a retirement, so we'll see. You know, in the next 10 or 12 years, if I'm still doing medicine, or am I doing law or engineering or some hybrid? Who knows?
I love it. All right, if you had to get up and sing karaoke right now, what song would you sing?
Frank Sinatra's My Way. How about that?
All right. That's a different one. Dr. High, thanks for joining us today.
Thank you for having me.
Hope Cook signing off with Dermcast Live.